So very good evening, everyone. Hope you are doing well. Today I'm going to do a journal club. I'm going to present a recently published study in June 2024. This was about tirzepatide for the treatment of obstructive sleep apnea and obesity. This will be first in this kind of a series of journal club. And in the coming weeks and months, I'm going to share with you all many such studies, which will be very helpful for you all in your day-to-day clinical practice, plus also an important aspect for the exams. So let's start right away. And this is my lecture number 76 of my lecture series. Of course, you'll all know that I have 75 other lectures, which are extremely useful for the exam preparation for the specialty exam, European Board, MRCP, as well as in your clinical practice. So let's start right away. So as I mentioned, today I'm going to present in the journal club recently published article in the New England Journal of Medicine about tirzepatide for the treatment of OSA and obesity. So just a bit of background about obstructive sleep apnea. This is characterized by disorder breathing during sleep, leading to hypoxemia, hypercapnia, and recurrent arousals. The prevalence is about over 900 million people worldwide, with 40% having moderate to severe disease. We'll look at what is classified as mild, moderate, and severe obstructive sleep apnea in the coming slides. There is a definite link to cardiovascular disease and other serious health issues. And in the current treatment options available, the positive airway pressure therapy, which is CPAP or BiPAP, is common but has variable adherence because it is quite cumbersome with the face mask and the kind of pressure which it generates. Many patients do not comply with it. And I have so many patients who present to us for the treatment of obesity, having had obstructive sleep apnea and had non-compliance to CPAP or BiPAP. And in terms of other modalities of treatment, there is mandibular advancement devices and upper airway surgery, none of which are universally effective or non-invasive. Bariatric surgery has shown benefits in adults with obstructive sleep apnea. However, owing to the invasive nature of the surgery, it is not a feasible approach for many persons with obstructive sleep apnea and obesity. So we talked about the risk, how it is linked to cardiovascular disease. I'll be talking in the next slides. What are the risk factors for development of obstructive sleep apnea? Older the age, so OSA prevalence increases with age, plateauing in the 6 to the 7 decade. Male sex, obstructive sleep apnea is 2 to 3 times more common in males, but the risk evens out peri and postmenopause in females as well. So strong correlation with the BMI, a 10% weight increase can lead to a 6-fold increase in the OSA risk. In obese males, 63% have moderate to severe OSA. In females, 22% of the obese individuals have OSA. Even having craniofacial and upper airway abnormalities like short mandible, wide craniofacial base, and hypertrophy of the tonsils and adenoids are a risk factor for developing obstructive sleep apnea. Less established risk factors is smoking. Smokers have a nearly 3-fold increased risk of OSA. Family history, potential genetic predisposition with about 40% of the AHI variants attributed to genetics. We'll look at what is the AHI index in the next slides. Nasal congestion, this doubles the risk of OSA, improves post-correction. Improvement post-correction is variable. High levels of nitrogen dioxide in the environmental exposure and particulate matter may increase the OSA risk, and certain substances and medications like alcohol, benzodiazepines, narcotics, and possibly even gabapentinoids may exacerbate obstructive sleep apnea. What are the complications which can happen as a result of obstructive sleep apnea? Drowsy driving and motor vehicle crashes. So motor vehicle accidents are 2 to 3 times more common among OSA patients compared to those without OSA. OSA can also lead to neuropsychiatric dysfunction in the form of inattention, memory, and cognitive deficits, resulting in impaired executive function and increased errors and accidents. Additional manifestations include moodiness, irritability, depression, psychosis, and sexual dysfunction. OSA can also increase the risk for systemic hypertension, coronary artery disease, cardiac arrhythmias, heart failure, and stroke, particularly when OSA is moderate to severe and untreated. And classically, OSA is also associated with group 3 pulmonary hypertension, especially when OSA coexists with obesity hypoventilation syndrome or chronic lung disease. Severe hypoxemia may also cause secondary polycythemia. So that's why medication which will be effective in such a condition which is having so many complications will be extremely useful. And that was the whole idea and the background of carrying out this study. Some of the other complications of note for obstructive sleep apnea is metabolic syndrome and type 2 diabetes. We see higher prevalence of insulin resistance and type 2 diabetes with an independent association between OSA severity, insulin resistance, and diabetes. Severe OHA, which is classified as the AHI index of more than 30 events per hour, increases the risk of insulin diabetes by approximately 30%. OSA exacerbates cardiometabolic risk associated with metabolic syndrome, increases glucose, triglyceride levels, inflammation, arterial stiffness, and atherosclerosis. Even for that matter, it is associated with non-alcoholic fatty liver disease. Severe OSA patients have 2 to 3 times higher prevalence of NAFLD independent of obesity. Some miscellaneous complications are increased risk of gout, possible association between even cancer and nocturnal hypoxemia, and slight increase in the risk of unprovoked venous thromboembolism in patients with severe nocturnal hypoxemia. So you can imagine the implications of having OSA. So tirzepatide, we all know now, it's one of the most popular drugs for the management of obesity and obesity with diabetes as well. It is a dual glucose-dependent insulinotropic polypeptide and glucagon-like peptide receptor agonist. It has clearly shown promises in terms of clinical evidence as well as in our clinical practice as well for reducing the body weight, improving the cardiovascular risk factors, and this study will show us its potentiality for even helping to treat obstructive sleep apnea. So the AHI, which I was referring to in my previous slides, is called the apnea-hypoapnea index. What it is exactly, it is a measure used to assess the severity of obstructive sleep apnea. It's very important to note all these terms because once I start the description about the study, these terms will appear very frequently. And if you already have an idea about the background of these terminologies, the whole study will be very simplified for you. So the apnea-hypoapnea index is a measure used to assess the severity of OSA by quantifying the number of apneas and hypoapneas experienced per hour of sleep. To calculate the AHI, first of all, we identify the apneas and hypoapneas. This is done as a part of polysomnography, by the way. So apneas is complete cessation of airflow for at least 10 seconds. What is hypoapnea? It is partial reduction in airflow, more than 30% decrease for at least 10 seconds with an associated oxygen desaturation of greater than or equal to 4% or an arousal from sleep. So very important how these two definitions have been given, apnea and hypoapnea. So we have to count the number of events. So count the number of apneas recorded during the sleep study and count the number of hypoapneas recorded during the sleep study. Calculate then the total number of apnea and hypoapnea events. So sum the total number of apnea and hypoapneas to get the total number of respiratory events. Then determine the total sleep time. This is the total amount of time the patient spends asleep during the polysomnographic study measured in hours. It's also called the TST. So very easy, we calculate AHI is equal to total number of apneas and hypoapneas divided by the total sleep time in hours. For example, if a patient has 20 apneas and 30 apneas over a total sleep time of 6 hours, the AHI will be calculated as 20 plus 30 divided by 6. That is equal to 50 by 6. So that's around 8.33 events per hour. That will be your AHI. So that's how we calculate the AHI. Now, how do we grade the severity of the obstructive sleep apnea? On the basis of that, mild OSA is AHI of 5 to 15 events per hour. Moderate OSA is AHI of 15 to 30 events per hour. And severe OSA is AHI of greater than 30 events per hour. So this is how we grade severity on the basis of AHI. So as I mentioned, this is how we classify, and it helps to assess the severity of sleep apnea. Now coming to the study, now that you have a basic idea about the background, about the OSA, its implications, its complications, and how to calculate the AHI as well, the other part for the study will be very, very easy. So the overview of the study, the objective was to evaluate the efficacy and safety of tirzepatide, which is a dual GIP and GLP-1 receptor agonist in treating adults with moderate to severe OSA and obesity. So now you'll already know what is moderate to severe ESA based on the AHI index, which is more than 15 basically. So it will be more than 15 to 30 for moderate and more than 30 for severe OSA. So the category of patients was moderate to severe OSA and obesity. So key aspects of the trial included participants underwent a 4-week screening period before being randomly assigned to one of the two trials and then randomly assigned to either tirzepatide or placebo group. All the patients received lifestyle counseling, which was focused on maintaining a healthy diet, aiming for a 500 calorie daily deficit, kilocalorie daily deficit, and engaging in at least 150 minutes of physical activity per week. Randomization was managed through a web-based interactive response system and was stratified based on trial, geographic region, and the baseline apnea-hypoapnea index, severity, and sex. To ensure a balanced representation, the enrollment of women was capped at 70% of the total participants. Trial was double-blinded, meaning neither the participants, investigators, and the sponsor did not know which group participants were assigned to the tirzepatide or placebo. So these were the key aspects of this trial. It was a two-phase. Double-blinded. So it was a phase 3 trial. It was double-blinded, randomized control trial. It was called the SURMOUNT OSA. So this trial which we are discussing is called the SURMOUNT OSA, and this involved 60 sites across 9 countries. So these two trial groups included. First trial, one group included participants who were unable or unwilling to use the positive airway pressure ventilation therapy. And the trial 2 included participants who had been using PAP therapy for at least 3 consecutive months at the time of screening and who already planned and agreed to continue PAP therapy during the trial. So these are how the two trial groups were defined. So participants enrolled in the study were adults with moderate to severe OSA. So I already mentioned to you, more than or equal to 15 events per hour, and obesity. So they choose patients who had a BMI of more than or equal to 30. So from a period of June 2022 till March 2024, 2 trials were conducted, as I mentioned, trial 1 and trial 2, involving total of 469 participants who were randomly assigned to receiving tirzepatide or placebo. Trial 1 included 234 participants and trial 2 around 235. So almost equal number across the two trial groups. As I already mentioned to you, what is trial 1 and trial 2 groups. So trial 1 and trial 2, the main demographic and baseline characteristics was the mean age was around 48 to 50. Gender was, as I mentioned, almost 67 to 70% males, rest females. Ethnicity predominantly 65 to 70% white. Mean BMI was around 39. And mean AHI events, very important, was around 51 events per hour. So 50 to 51 events per hour was the main baseline characteristic across both the trial groups. And this slide shows more in detail of the demographic and clinical characteristics of the participants at the baseline. We can clearly see across both the groups in trial 1 as well as the trial 2, and then assigned to tirzepatide or placebo, the distribution for the age, for the female sex, for the race or ethnicity, body weight, BMI, waist circumference, AHI, even OSA severity, and even something called the PROMIS sleep-related impairment T-scores was almost similar across both the groups of trial 1 as well as trial 2 and divided equally in the tirzepatide and the placebo arms. So we'll be looking about this patient sleep-related impairment scores in the next slides to give you a more idea about this. And even for the other baseline characteristics like the hsCRP, prediabetes status, glycated hemoglobin at the baseline, dyslipidemia, again, these were equally similar across the trial 1 and trial 2 groups at the baseline. Exclusion criteria, the presence of type 1 or type 2 diabetes was an exclusion. A participant reported change in body weight of more than 5 kg in 3 months before the screening was an exclusion. So basically, all these patients were not diabetic. So that's another very important thing to note. Okay, so diabetes was an exclusion. Planned surgery before sleep for sleep apnea or obesity was an exclusion as well. A diagnosis of central or mixed sleep apnea was also an exclusion. And presence of major craniofacial abnormalities was also in the key exclusion criteria. So participants were treated with tirzepatide or placebo over a planned 52-week period, which included a dose escalation a phase of up to 20 weeks. So initial dose of tirzepatide was 2.5 mg per week, which was then increased by 2.5 mg every 4 weeks. The dose was adjusted until the maximum tolerated dose of either 10 or 15 mg was reached, depending upon the participant's tolerance. Then I already mentioned to you about the AHI. So the AHI they measured by the lab polysomnography at screening, week 20, and then at week 52. So at screening, then at week 20 and at week 52. So data from the polysomnographic studies was scored centrally with the use of an American Academy of Sleep Medicine Rule 1B for identification of hypoapneas and apnea. We already looked at what is the definition according to the American Academy of Sleep Medicine in my previous slide of apnea as well as hypoapnea. What are the primary and the secondary endpoints looked at in this study? Change in the apnea-hypoapnea index, also measuring the number of apneas and hypoapneas per hour of sleep. So that was the primary endpoint. Secondary endpoint was percent change in the EHI. What was the difference in the body weight? The very important terminology I'm going to tell now is hypoxic burden, high sensitivity C-reactive protein, systolic blood pressure, and even patient-reported outcomes on the sleep impairment and disturbance. We are going to look at all of this in the next slides now to try and understand what are the meaning of each one of them and their correlation with obstructive sleep apnea. So what is the role of hsCRP in OSA? So research has shown clearly that individuals with OSA have often higher levels of high sensitivity CRP compared to those without OSA. This suggests that OSA may contribute to systemic inflammation. Higher hsCRP levels have been linked to more severe forms of OSA. The frequency and severity of apneas and hypoapneas may correlate with the increased inflammation as measured by hsCRP. So we know that what is the impact of hsCRP? Elevated hsCRP levels in OSA are associated with an increased risk of cardiovascular disease such as hypertension, coronary artery disease, and even stroke. Chronic inflammation and intermittent hypoxia in USA may contribute to these elevated hsCRP levels and an increased cardiovascular risk. OSA is also linked to metabolic syndrome, which includes obesity, insulin resistance, and dyslipidemia. Elevated hsCRP levels may reflect inflammation associated with metabolic disturbances. So this was again an important secondary endpoint. Why? Because we wanted to see if there was any decrease in the hsCRP levels on treatment with tirzepatide. So what usually happens is hsCRP. So the data we have so far for the CPAP, a common treatment for OSA, has shown to reduce hsCRP levels. Improvement in the sleep quality and reduction in the apneas and hypoapneas with CPAP may lead to decreased systemic inflammation and lower hsCRP levels. What is the effect of tirzepatide for the hsCRP? That we are now going to look at in this study. And what is the result when we look at in the results section. So while hsCRPs are not used for diagnosing OSA directly, elevated levels provide us additional information about the inflammatory state of the patient and the potential presence of OSA-related complications. So monitoring hsCRP levels can be useful in assessing the effectiveness of OSA treatments and their impact on systemic inflammation and related health risks. Now, the concept of hypoxic burden in ASA. This represents the total amount of time or severity of oxygen desaturation experienced by the patient during sleep. It encompasses both the frequency and degree of oxygen level drops. So what are the main components of a hypoxic burden? Oxygen desaturation refers to reduction in blood oxygen levels, usually measured by pulse oximetry. In OSA, this occurs during apneas and hypoapneas. The number of desaturation events per hour is the desaturation index. Total time spent with oxygen levels below a certain threshold, such as below 90%, is the duration of hypoxemia. And the minimum oxygen concentration level reached during the sleep is another component of hypoxic burden. Why is it important? Because repeated episodes of hypoxia can lead to increased blood pressure, systemic inflammation, and endothelial dysfunction, which can contribute to hypertension, heart disease, and stroke. Chronic hypoxia is associated with metabolic syndrome, including insulin resistance, obesity, and dyslipidemia. Again, recurrent hypoxemia can cause cognitive dysfunction and increased risk of neurodegenerative disorders as well. So, comprehensive sleep study like polysomnography records various physiological parameters, including oxygen saturation, to help us assess this hypoxic burden. Pulse oximetry measures the blood oxygen levels and can be used to monitor oxygen desaturation events and calculate metrics like desaturation index, which we looked at, and the time spent below the specific saturation thresholds. And evaluates the effectiveness of CPAP monitoring, evaluates the effectiveness of treatment in reducing the hypoxemic burden. Now, impact of the treatment so far we know is CPAP is effective in elevating the hypoxemic burden by preventing apneas and hypoapneas and thereby maintaining more stable oxygen levels throughout the sleep. Other therapies so far, positional therapy, oral appliances, surgical options may all help to reduce the oxygen burden, hypoxic burden by addressing the airway obstruction in different ways. Whether tirzepatide will be able to do this, we'll look at in the results of this study. So what were the results which were found out in this phase 3 study, which was done? So there was a definite reduction in the apnea-hypoapnea index. So in the trial 1 group, so we can clearly see there is a mean AHI reduction of 25.3 events per hour with tirzepatide versus only 5 with placebo. Again, there is a mean AHI reduction of 29 events per hour with tirzepatide versus 5.5 with the placebo. So clearly showing the benefit of tirzepatide over placebo in the reduction of the AHI, which is such an important marker for the OSA. Also, we clearly notice a significant reduction in the body weight with tirzepatide compared to the placebo in this 52 weeks. So we can clearly see from this graph, so change from the baseline, so change in the apnea index in trial 1, we can clearly see in both these charts right on the top. And even in terms of the body weight, we can clearly see almost 16% drop in the trial 1, 16%, and almost around 17% drop in the body weight from the baseline in the trial 2 group. So we can clearly see that there is a change in the hypoapnea-apnea index in the tirzepatide people, the patients receiving tirzepatide versus the placebo, definite advantage, and even in terms of the body weight as well. So hypoxic burden, what was it found? It was found to be reduced with tirzepatide. hsCRP and blood pressure was also improved on tirzepatide, and the patient-related outcomes, improvement in the sleep-related impairment and disturbance with tirzepatide was clearly found in this study. So these were the findings and the primary and the key secondary endpoints which they were looking at in the beginning, and we will look at the understanding of what is patient-related outcomes from sleep impairment and disturbance. So this was recurrently referred to in the previous slides. We'll look at this concept as well. So the patient-reported outcomes on sleep impairment and disturbance, the PROMIS short form sleep-related impairment consists of 8 factors that the participant can recall in the past 7 days, with each factor rated on a 5-point scale, from not at all to very much. Scores for individual factors were totaled to obtain a raw score that was converted to a T-score, with a mean score of 50 and a standard deviation of 10, with higher scores indicating more sleep-related impairment. So the whole purpose of this PROMIS short form sleep-related impairment score was to assess the impact of sleep impairment on daytime function and overall quality of life. This included 8 items that focuses on how sleep issue affects the daytime activities, cognitive function, mood, and fatigue. Example items was, I had trouble staying awake during the day. I felt irritable because of poor sleep, and I had a hard time getting things done because I was sleepy. So this is basically assessing the impact of the sleep impairment on daytime function and overall quality of life. So this was one of the patient-reported outcomes which was used in this study. So one of them. What was the other? The other was the PROMIS short form sleep disturbance 8B. This again consisted of 8 factors. Again, the purpose was to measure the quality, depth, and the restfulness of the sleep. So this was the difference between the two. So the PROMIS short form sleep-related impairment assessed the impact of sleep impairment on daytime function and overall quality of life, whereas the PROMIS short form sleep disturbance score measured the quality, depth, and restfulness of the sleep. Again, it included 8 items that address issues related to sleep quality, sleep duration, and frequency of sleep disturbances. Example items was, I had trouble falling asleep. I woke up several times during the night and my sleep was refreshing. So this is the difference between the two patient-reported outcomes, which were used on sleep impairment and disturbance in this particular study. The other scale which was used was a Epworth sleepiness scale. This is an 8-factor participant reporting measure that asks the participant to rate on a scale of 0. 0 is will never dose, and to 3, high chance of dosing, their recent typical likelihood of dosing in 8 different daytime situations. DSS total score is the sum of the 8-factor scores and ranges from 0 to 24, with higher scores obviously indicating greater daytime sleepiness. So this was the outcome which was reported from the pooled trial 1 and trial 2 patient-reported outcomes. We can clearly see that there is a change in the PROMIS sleep-related impairment score, as well as there is a change in the PROMIS sleep disturbance T-score. There is a clear advantage for tirzepatide over the placebo, and the p-value was statistically significant. So these were the two things which were another two things which was looked at in the study. So if you look at the results overview, tirzepatide significantly reduced the apnea-hypopnea index by up to 29.3 events per hour, which is actually 58.7 reduction from the baseline. In contrast to placebo groups, only a reduction of only 5.3 events per hour, which is only a 3% change. This reduction is clinically relevant as the American Academy of Sleep Medicine considers an AHI of 15 or more events per hour as significant. And if you can imagine that if there is a 50% improvement in AHI, then the patient will be only reduced to mild or even no sleep apnea. So almost a 50% reduction, you can say that it will come down directly in the mild category. So you can imagine from a severe category, patient can come into a moderate category, and from a moderate to a mild category, just on the with the usage of medication like tirzepatide. So up to 50.2% of the participants treated with tirzepatide in this SURMOUNT OSA trial achieved a combined key secondary endpoint of fewer than 5 AHI events per hour or 5 to 14 AHI events per hour, and an Epworth sleepiness score of 10 or less. So we can clearly see an improvement in the Epworth sleepiness scale as well. These thresholds indicate a severity level where positive airway pressure therapy may not be recommended and will not be required. The reductions in AHI was accompanied by meaningful improvements in hypoxic burden, which is important for assessing the risk of cardiovascular complications and death related to OSA. These benefits were observed regardless of whether participants use concomitant PAP therapy, highlighting the potential of tirzepatide as an alternative treatment for those unable or unwilling to adhere to the PAP therapy. So when I was talking about the reduction, we can clearly see in terms of the hsCRP, there was a definite reduction in the tirzepatide group versus the placebo. When we looked at the body weight, of course, when we looked at the reduction of the AHI as well, and we looked at the blood pressure as well, and we already looked at the changes in the sleep-related impairment and sleep disturbance T-scores as well. So clearly, tirzepatide had an advantage over the placebo across the two trial groups, trial 1 and trial 2, whether the patient was on PAP or not on PAP. Adverse events in this study typically observed with tirzepatide and GLP-1 receptor agonists. Mild to moderate GI events were observed, and they were mostly, they were mostly of mild to moderate category, and usually occurred during the primary dose escalation period only. There were no much differences observed between tirzepatide recipients and placebo recipients with regard to reported gallbladder-related events like gallstones or hepatic or renal events for that matter. So there was no difference observed between tirzepatide and the placebo arms. So to summarize now, what are the strengths of this study? This trial was conducted globally, enhancing generalization of the findings. Study had an adequate size sample, ensuring robust statistical power. The study ensured relevant representation of the women. As I told you, the men were capped at 70%, so had relevant representation of women who are typically underrepresented in other obstructive sleep apnea trials. In terms of endpoints, so multiple obstructive sleep apnea related patient-reported and cardiovascular related endpoints were assessed, providing a very comprehensive view of the burden of the OSA. The weight reduction observed in the placebo group was similar to the other anti-obesity medications, suggesting a similar adherence to lifestyle intervention. The study did not limit enrollment to participants with current symptoms, which may inform broader treatment decisions in the future clinical practice. And the design of the two independent trials involving participants with or without current PAP therapy provides insights into the effect of tirzepatide treatment in these prevalent patient populations. What are the limitations of this study? It was a comparatively shorter design in terms of long-term cardiovascular outcome study. So the ongoing SURMOUNT morbidity and mortality trials may provide additional information. The trial excluded participants who did not have obesity and did not analyze the effect of intervention in the people who were just overweight or normal BMI. Trial 2 was not designed to investigate the potential effect of treatment interventions on adherence to PAP treatment, and this was not pre-specified endpoint for analysis. The trials were not designed to assess whether the results differed according to presence of participant symptoms at baseline. The thresholds of minimally clinical important changes for the PROMIS SRI and the PROMIS SD scoring have not yet been established in clinical practice, and therefore clinical importance of these observed improvements remain to be evaluated. And last but not the least, the trials did not investigate a period of treatment with tirzepatide longer than 52 weeks, despite we know that obstructive sleep apnea affected patients lives over many, many years. So these were some important strengths and the limitations of this study. And now to wrap up, key learning points for the clinicians. We need to have a holistic treatment approach. Tirzepatide offers a comprehensive treatment for obesity as well as obstructive sleep apnea by addressing both obesity and sleep disordered breathing. Unlike traditional mechanical treatments, significant weight loss is critical outcome of tirzepatide treatment, which is beneficial given the strong link between obesity and OSA. Treatment with tirzepatide resulted in improvements in cardiovascular risk factors, such as we see that reduced hsCRP, as well as lowering the systolic blood pressure, potentially reducing the risk of cardiovascular complications in OSA patients. It had a clear improvement in patient-reported outcomes. Patient reported better sleep quality and fewer sleep-related impairments, highlighting the positive impact of tirzepatide on overall sleep, health and quality of life. And this has clearly a potential for broader application. The findings suggest that tirzepatide could be beneficial for a wide range of obstructive sleep apnea patients, including those with varying adherence to PAP therapy and those with different baseline symptoms. These are the references. So thank you so much. Hope you like this journal club. I'll be coming up with more journal clubs in the coming weeks and months. And if you do like this journal club presentation, please subscribe to my channel and subscribe to my lecture series. Many thanks.